At the outset, let me thank Dr. Sanjay Kumar for having me here in Bhopal for the workshop at the CAB. I've been asked to speak on complications of GRD with a focus on Barrett's. We know that GRD, there are various clinical subsets. Some of them are non-erosive disease, which means that you send them for an endoscopy and the endoscopy is normal, but yet they have symptoms. Then you have a group of patients who have erosions. Those are the kind of patients who do well with PPI. And then you have a subset of patients who may or may not have symptoms, but they have something called Barrett's. And what is Barrett's? Barrett's is where the normal squamous epithelium of the esophagus changes to a columnar epithelium. So when you have this change, you call it Barrett's. And the importance of Barrett's is that it can predispose to esophageal adenocarcinoma. We all know that the majority of esophageal cancers are squamous cell cancers, but we do recognize that at the lower end, there is an increased number of adenocarcinomas that we are now recognizing, and we now also realize that a vast majority of these adenocarcinomas are related to underlying Barrett's epithelium, and that is why this whole importance. We also know that various extraesophageal manifestations may be there, which are complications of reflux. Can we just have less noise there, please, in that corner? We can have a peptic stricture. We have bleeding, and of course, we're talking about Barrett's cancer today. Now, peptic strictures are not so common, at least in the Indian context, but we do see these patients, and they do pretty well with dilatation. They often come to us. They say they have long-standing symptoms of heartburn, and they say, now I can't swallow, food is getting stuck, and sometimes we find that they have strictures. We dilate them. Most of them are fairly simple strictures, which are short, less than 2 centimeters straight and at the lower end. And one can use either a bougie or a balloon to dilate. And the advantage of using a balloon is, of course, you don't need to use fluoroscopic control. Now, coming back to Barrett's, what do we do when we see a patient with Barrett's? We need to know, first, is it just an irregular Z line or the squamocolumnar junction? Or it's actually there's an upward migration of this into the esophagus. So the first thing we need to do is define the upper folds of the stomach and then look at this pinkish kind of epithelium that we see. We also like to document as to the measurement, how much of it is circumferential, how much is the maximum extent. This is basically for us to follow up these patients more than it has an absolute relevance, though we know that the longer the segment of Barrett's, more the risk for cancer. Now, where do we find this Barrett's? When those of you who are doing endoscopy will realize that most of it is found on the right half of your screen. It's the same thing for erosions. That's also found between 12 to 6 o'clock, between 1 to 4 or 1 to 5 is a usual area, and that is where you should focus on looking for Barrett's for dysplasia and so on. So, if you are looking for early cancer, the area to focus on, obviously you will see the whole, but more attention to the right half of your finger. Now just to show you some images, here you're finding that they're definitely, you're finding that this area is definitely, this epithelium is different. And then when you look closely, again you find that there are these tongues of Barrett's, and this again is a large tongue of Barrett's. But where is the abnormal area? Is there an early cancer or a pre-cancer situation here? And if you look very closely here, you'll find that this area definitely is a little depressed. So the first message is that to look for Barrett's, you don't always need very fancy equipment. Even white light endoscopy is reasonably good. You need patience and do a meticulous examination. And of course, you must look for abnormalities in the color, the texture, see if it's nodular, see if it's depressed, and so on. When we use things like NBI, there are various classifications. I'll just show you one of these. Here you find that we are able to see the surface pattern in these kind of pits here, and this is usually non-neoplastic pattern of the Barrett's epithelium. Here again is non-neoplastic, but you appreciate that these are more tubular, right? So this is more likely to be specialized intestinal metaplasia. So non-neoplastic, but slightly higher risk for cancer in the future compared to this. Here you are not seeing any surface pattern at all. You only see vessels which are quite regular. So this is kind of semi-indeterminate, and this is again a feature often of intestinal metaplasia. But if you look down here, you find that the surface pattern and the vessels are both abnormal, and this is neoplastic. So using NBI, you can identify these areas with a little more confidence. Now if you look at this area, you can make out this tubular looking surface pattern here. Here they are more rounded. But is there any area which is abnormal? You can see here that yes, this area looks a little, these vessels look a little tortuous. And if you zoom in here, you'll find that these vessels are certainly a little more tortuous and irregular. So there is no doubt that if you use technology and magnification, you can pick up these lesions with far more confidence. And this is the early lesion that you would want to see and deal with it, rather than allowing it to get grow into a cancer over a period of time. Therefore, what are the hierarchical steps that we do? We first interrogate with white light endoscopy with magnification. We say, okay, this patient's got Barrett's, he's got this much circumferential extent, he's got so much of maximum extent of the disease. Then look if there's something that looks abnormal. Then we put NBI, and then we look at the surface pattern and the vessel pattern. So here again, looking, we're not finding anything very obvious. Does it look normal? But when you use your zoom, you can find out very clearly that this area here, which is also here but can't see too well, but here you can definitely see that there's a change, abnormal vessels, abnormal surface pattern. So this definitely is high-grade dysplasia in normal. Again, white light endoscopy shows you this is normal, this definitely is an abnormal area, and on NBI you can appreciate these vessels even better. You can see it on white light as well, but NBI just makes it a little more easy. So how good are these techniques? And if you look at the negative predictive value tells you how confident you are to say that, okay, there's nothing sinister. Negative predictive value is excellent when you use white light endoscopy and NBI with magnification. So therefore, those of you who do not want to keep biopsying for Barrett's, if you are able to master this and say my negative predictive value is pretty good, you can avoid biopsy except in a suspicious area. what I was trying to show you yesterday, but we could do that too well. This is an island of Barrett's, and after we have done the NBI examination, looked at the vessels, we have sprayed acetic acid, and see how beautifully you see the surface pattern. So nicely brought out, very regular, no abnormality at all. So when you do this, you can quickly look at the mucosa and say, okay, this looks good, I'm not going to waste my time biopsying any further, and you can come out. Now, how good is this acetic acid technique? We find that when we put acetic acid, if there is neoplasia, there's a focal loss of acetowhite. So that area doesn't take up the whiteness, or it disappears, or the surface pattern is irregular, then you say that this is a suspicious area and is likely to be neoplastic. If you look at the sensitivity, specificity, and negative predictive value, pretty high. So I think this should be a part of routine clinical use, because acetic acid is extremely cheap, easy to use, and you can get fantastic information by using it. Just to show you one of our patients here, this is the acetic acid here. You find that it's not all that white, it's looking a little pinkish red, and you can see this slightly heaped up mucosa. So this is a Paris 2A morphology, size about 2 centimeters. This villiform appearance and clumped kind of surface mucosa and loss of acetowhitening. So this, you can say, is fairly suggestive of a sinister lesion there. Is this deeply invasive cancer, or is it something that you can do some endotherapy? If you look at the ones on the right, if you find a lesion that is depressed or excavated or very nodular, what we call a Paris 1S or 1P lesion, and if you have a very obscure surface, that's more likely to be an aggressive tumor which may not be managed with endotherapy. But on the other hand, if it's more flat, like a 2A, 2B lesion with an irregular microvascular microsurface pattern, that can be perhaps superficial and can be managed with endotherapy. How do you ablate these lesions? We often do it with endoscopic mucosal dissection with band EMR, sometimes with CAP EMR, and en bloc if possible, or piecemeal if required. Sometimes people are now resorting to ESD as well. What happens when you ablate this bit of abnormal looking area and then leave the rest of the Barrett's and you just follow them up with surveillance? So if you leave them alone, you find that about up to a third of these patients come back to you with a recurrence of high-grade dysplasia or cancer. The reason is that the Barrett's epithelium itself is predisposed to cancer. So unless you ablate that, you do not bring down the absolute risk of cancer in the future. And hence, once you've done the resection of that abnormal area, you have to ablate the rest of the Barrett's, and that in the West they use radiofrequency ablation. This is not available to us in India. So if it's a small area, you can do an endoscopic mucosal dissection itself. If it's a bigger area, you can use an ESD. People have tried APC, but there are some problems with it. But I guess in the Indian situation, maybe that's an option that we could still consider. People are now using the cryotherapy. Now just show you one of our patients. Here you can find, we have sprayed acetic acid, and you can find that this area definitely is suspicious, loss of acetowhitening, and here, this again, a more close-up of that. Let's see if this video plays. Sorry, this video is not playing. But what we did is we used a band EMR and resected that area, it was 2 centimeters, clean resection. Obviously there was some little bleeding, which we managed with the instruments that are available. And what did we find on histology? We found a focal area of high-grade dysplasia, and this patient, therefore, we ablated the little bit of Barrett's that he had, again, after 3 months with the band EMR technique, and this patient is on follow-up. So what is the protocol for following up? If you have low-grade dysplasia, you follow them up at 1 and 3 years. If you have high-grade dysplasia or cancer, you need to do a very close follow-up, 3 monthly, so for the first 1 year and then once a year. So the message is, Barrett's is precancerous. If you pick up dysplasia and Barrett's, dissect that area, ablate the background Barrett's, whatever technique that you have, and follow them up. This is most important. It's not a one-time procedure, but you need to follow them. Obviously, the other option would be to consider surgery, remove half of that esophagus. I think that would be a little too drastic to do for a pre-cancerous state, and hence endotherapy is perhaps the most important thing available to us now. We can stop here and maybe take up questions.